Yeah, we're good. Okay. Welcome on this historically frigid Tuesday morning here for the Cuyahoga County Human Resources Appointments and Equity Committee. Roll call, please.
Calling the roll, Ms. Conwell. Ms. Conwell is absent. Mr. Germana?
Here.
Mr. Gallagher? Mr. Hairston?
Here.
Ms. Simon? Ms. Simon is absent. We have a quorum.
Could I have a motion for Ms. Conwell and Ms. Simon in their absence?
So move. Second.
All in favor?
Aye.
Thank you. Public comment related to the agenda?
No, Mr. Chair, no one has signed in.
Approval of the minutes. In your packet, we have the minutes of October 21st meeting. If they're in order, I'll accept a motion.
So move. Second.
All in favor?
Aye.
Against? Thank you. 2014-0258.
Resolution 2014-0258, a resolution making an award on requisition number 30390 to Caremark PCS Health LLC in the amount not to exceed $40,189,733 for group healthcare benefits for county employees and their eligible dependents, including pharmacy benefit management services for the period 1/1/2015 through 12/31/2017, authorizing the county executive to execute the contract and all their documents consistent with said award in this resolution, and declaring the necessity that this resolution become immediately effective.
Thank you. Would it be easier to read all these and take care of them all at one time?
Yes,
So if
sir.
we can have 5-9 and 6-0 also.
Resolution 2014-0259, a resolution making an award on requisition number 30390 to Medical Mutual of Ohio in the amount not to exceed $116,156,022 for group healthcare benefits for county employees and their eligible dependents, including medical and pharmacy benefit management services for the period 1/1/2015 through 12/31/2017, authorizing the county executive to execute the contract and all other documents consistent with said award in this resolution, and declaring the necessity that this resolution become immediately effective. Resolution 2014-0260, a resolution making an award on requisition number 30390 to United Healthcare Services, Inc. in the amount not to exceed $68,308,890 for group healthcare benefits for county employees and their eligible dependents, including medical benefit management services for the period 1/1/2015 through 12/31/2017, authorizing the county executive to execute the contract and all their documents consistent with said award in this resolution, and declaring the necessity that this resolution become immediately effective.
Thank you. Ms. Durkin?
Good morning, Lisa
Welcome.
Durkin from the Department of Human Resources. We bring before you today for your consideration the 3 years, the next 3 years of healthcare, major medical and prescription drug contracts for county employees. These contracts cover approximately 6,300 county employees who elect benefits with the county and their dependents. We negotiated in good faith, and we feel as though we got a good rate of inflation, better than the other municipalities and the other markets are showing. As a matter of fact, we are having a few more regional entities join us at the beginning of the year because we are doing so well. But these are for the county employees, and I have given you a memo yesterday and showed the costs associated with them and the total that have enrolled thus far. Of course, as you know, that enrollment can change monthly and does according to qualifying events that our employees may experience. But I feel like I've laid it out for you, and I'll take any questions that you have.
And there was concern that Kaiser was dropped. Do you want to care to address that?
Yes. So for years, and to my knowledge, for a good 7 years, we have watched as Kaiser's membership has become less and less. And the reason for that is because the cost to the employees and to the county has risen. But not only that, Kaiser's network has gotten smaller and smaller. In this area, Kaiser, now HealthSpan, really their network started eroding, and their own doctors started also working for the other networks here in town. So when we only had 282 enrollees or members in Kaiser this year, and we were at the negotiations table and once again was faced with a price increase and once again was faced with the fact that they could not offer us a self-insured product. They continued to offer us a fully insured product, which quite frankly was becoming harder and harder to administer from our benefits office in accordance with the ordinances of procurement set forth by this council. So administration was becoming very, very difficult. When we got down to that low of attendance and looked at the money we were spending and the administration we were doing, it really just, and the fact that they still couldn't present us with a self-insured tool, it really became time to sever that contract. Now, our 282 employees were given opportunity to meet with us. I met with a lot of them personally because we did lunch and learns for all benefits information. From what I was hearing from employees, what we told employees was, first, I want you to go and talk to your doctor. Because many employees went and spoke to their doctor, and their doctor told them, oh, well, I'm also under MMO, or I'm also under United Healthcare, and employees then did not have to switch. I only know of one instance that an employee told me that their doctor was not covered somewhere else, and I never got confirmation of that back. So our benefits staff, who's here today, and I'd like to point them out there on the row there, our benefits staff also worked with a number of employees. Any employee who did make, an appointment with us or come to see us, we did take time to personally meet with and counsel them on their insurance options. And we did, we felt like we had customers who were walking away knowing what their options were and having other viable solutions. The other three networks that we offer really are comprised of kind of, I want to say, the rest of the doctors in town. So at first, the employees did feel like, you're only giving me a little bit of time to make a decision on a doctor. And we tried to tell them, no, you've got time to make a decision on a doctor. First, think about, if you were going to go to a hospital, where would you want to go? Where's most of your care? Kaiser was already sending people over to University Hospital. So let's think about that. Now let's see what that network looks like and what doctors are inside of that network. And most of them were satisfied when they were looking at those types of things. So while it's always our kind of want to give the most time to make any decision to our employees, we were kind of hampered by the negotiations process and the communications with that particular vendor and the other vendors. While it's our want in benefits to give folks, our customer employees, enough time and information to do everything that they need to do, we were a little bit hampered for time there, but we tried to make the most of what we had.
Okay. Any other questions? Mr. Germano.
Thank you, Mr. Chairman. Yesterday at the Committee of the Whole, we were trying to get through the budget, and healthcare did come up. In particular, the self-insurance and the balance. So, Mr. Schron's questioning is, what health insurance is trending. And why we were only going up 3%, and that had to do with our reserves. Then it seemed like the question was posed, but what really was never answered as to, is the reserve of $27 million reasonable or unreasonable in industry standards on self-insured funds, taking into consideration the amount of employees. So I think that needs to be answered, because if we're doing something that's not accepted industry standard, maybe we need to rethink this. And I don't know where, if council could make that decision, but council's made a decision on reserves for the HS levies and the general fund. So can you care to answer on that and just clear this up. And I guess the other thing I was talking about was, we have stop loss, but with 5,700 employees, you got to have reserves. So
Yes.
that was my position.
Yes, to the chair, to the councilman. Yes, and I wanted to clarify also, I also wanted to clarify that today. I did bring with me Jim Dustin and Dan Finland from Employee Benefits International, who have spoken to you before, and they are our consultants. And I would like for them to come up here and speak to what is industry standard. And when we talk about what we have in reserves, why the reason for that and what that gets us by way of our ability to remain a good risk pool. So I'll invite them up.
Morning.
Good morning.
In terms of reserve, Jim Dustin with Employee Benefits International. In terms of the reserve levels that we set, we run multiple projections for the county throughout the year to make sure that the healthcare fund is stable. Because we run a self-insured healthcare plan, we are required to hold reserves to fund what's called the incurred but not reported liability that exists should we end the plan at some point in time. So that would require us to carry somewhere between 4 and 6 months worth of reserves that would fund those claim liabilities, and that's what we consider to be fiscally prudent. What's unique about the county in particular is that because we also have a regionalization program that is part of that, new entities do join. So we want to make sure that we have enough reserves to fund all of those liabilities so that, as we're collecting premiums from those entities, that those premiums also offset the costs. So you have some range of flexibility. ORC guidelines provide some guidance to that, and we fit right within that mold. We are carrying, I think today, Dan confirmed for me, about 4.5 months, 4.5 months worth of reserves. We believe that to be adequate. It's not underfunded, it's not overfunded, and we think it's appropriate.
Mr. Chair.
So what is the number? What's that 4 to 6 months number?
So it funds, to make the example, if we shut the plan down on December 31st of this year, there are still claims that are being incurred all the way up until that point that we shut it down. Those claims actually get paid after the year is closed, so all the way out until, call it April or May. So we need enough money in the plan to be able to fund that liability, and it's considered to be fully reserved.
What's the number? You're saying that we need 4 to 6 months.
Correct.
How many dollars is that?
Dan, 6 months would be?
About $5 million.
That's anywhere from
30 to 45 million if you're carrying all the way out to 6 months. ORC guidelines would say you need a minimum of 90 days or 3 months.
Okay, so that is the justification for having $27 million balance.
Correct.
Okay, that's what I was getting at. Because where there was some confusion, and quite frankly, I was confused when Lisa said that, was it the federal government
Yeah.
required $7.5 million? So everybody's going, well, $7.5 million, we got $27 million. What's going on here? I mean, whoa, that's, so I knew we had to get down to the bottom of this. Right. So what you're saying is it's the incurred but not reported that is the most important part.
Correct.
Of this.
And to the chair, to the councilman, the 7.7 million that is our annual reserve set forth by the actuary and the federal government, that's in addition to the 6 month of runoff claims. So unfortunately, yesterday I didn't mention that 6 months of runoff claims. I guess that's what I was missing.
So, Mr. Chairman, so if I'm understanding what you just said, if we need 30 million plus the 7.5 million, where the 27 million really is not a big number.
Correct.
That's correct. You're a big healthcare plan, so, and the other component is essentially as it's growing, we have to continue to manage those reserves appropriately. So when new organizations come in, we build those reserves over time so that when those entities leave, if they choose to leave, that we have enough funding to cover those as well. So it's not a static number. And in fact, that number has to be managed every year because you do have inflation that erodes it on an annual basis. So once you set it, and if I can use just the example of if you set it at $10 million and you never move that dial, then you're going to erode those reserves over time. And at some point, you will not have enough money to fund that plan. So every year we run those projections. We reset what we think we need in terms of reserves. We also reset what we think we have in way of growth. So new plans coming in. So we want to make sure that we always have enough money to fund that run out.
Well, thank you for that explanation because from an insurance perspective, we understand what statutory reserves are and reserves are because of losses. But the way this was presented yesterday, I mean, I was even questioning what the heck's with this 27 million because it sounded like if we're only required to have 7.5. So I think it's important that, all of council understands that what we're doing here is reasonable and actually conservative in comparison to what it could be.
Yeah, I would say the county is very conservative. It is not unreasonable. One clarification I just want to make. ORC 9833 is what governs self-insured plans for the state of Ohio for government. It gives you guidelines. It doesn't give you hard and fast rules. So the guidelines would say it's a minimum of 90 days. There's no requirement that says it absolutely has to be 90 days. So you want to run the plan in a fiscally conservative manner. And again, that's what you pay us to do, and we calculate that really on an annual basis, and then we make adjustments based on who's coming into the plan and who's leaving.
Thank you.
Not dissimilar from what a city would have to have the 3 months, 90 days cash on hand. And if you're more fiscally prudent, it would be the 120 days. So it's really same thing. Mr. Harrison.
Thank you, Mr. Chair. Through the chair to Ms. Durkin, you mentioned the premiums that the municipalities pay. That goes into the reserve, that $27 million that we have? Where does the money that comes from municipalities for their enrollees, where does that go?
To the chair, to the councilman. Currently, we are keeping, if you will, we have our hospitalization self-insurance fund. Inside of there, we do separate out a regularly insured fund for those regional entities, and we keep all of their expenses and their revenue in there separate.
So they go to a separate account?
It's connected but separate, yes.
Okay. Second question. So, and I'm glad Councilman Germana brought the point up. I was kind of confused yesterday also about that point. And so that really goes back to why the 3% is chosen because of the other inspected enrollees plus the drawdown that happens. So that 3% is a good number to hold it, or should it be raised or should it be decreased? Well, I think that was a question from council members also yesterday.
Yeah, I can address that. When we run projections for the county, the industry would tell you today that standard inflation for healthcare purposes is running between 6 and 7%. We've projected the county increases at 1% in 2015 and 2% for each of the next consecutive years. It's our goal and has been for a number of years to beat the inflation rate, the general inflation rate of healthcare. We think that where we sit today is very prudent and doesn't need to be adjusted. Doesn't mean that it can't be adjusted, but you have to recognize that it's not a static environment. We pay claims on an annual basis or on a monthly basis. We could have a bad year. So when we're projecting out 3 years, we want to make sure that we've got enough money in the fund that if we do have a bad year that we can absorb it, but we're not adding necessarily to that reserve in that process. We are building the rate structures to break even.
Awesome, yeah, and I think that was the other part of the question too, that Joanna posed, and we thank you for clarifying that, because I hope we can relate information to the other council members who had those questions yesterday as well. And lastly, I see that it starts 1/1/2015 through 12/31/17. Thank you for bringing this to us early, so that we can get this matter moved. I know a lot of times they come 3-4 months, right, Chuck? Want us to approve things. So thank you so much.
And if the record would reflect Councilperson Simon here is in attendance, and Mr. Miller. Ms. Simon, did you have a question? I did, but I was going to answer. Okay, Mr. Miller?
My question also harks back to the testimony from yesterday's committee meeting where it was presented that the total cost for health care for 2012 was 66 million and something, and the total for 2013 was 73 or 74 million, and which was a 7% a $7 million increase, or 10%. And my question is did healthcare costs actually go up for us by 10% in 2013, or are there some one-time factors that make that not a true indication of what the change was?
Yeah, with the county, just for a point of clarification, the county went from spending just under 66 million in 2012 to just under 63 million in 2013, or excuse me, 72 million in 2012 to 67 million in 2013, back up to almost 74 million in 2014, projected through the end of this year. Your reference point is due to a couple of factors. Again, the county runs a narrow network model called Metro Health Select for roughly half of its population. This is the most popular healthcare plan that the county offers. It's also the lowest unit cost plan. Because we have multiple networks, we run United Healthcare, we run Medical Mutual, and this Metro Health Select plan. When we have big migration to that Metro Health Select plan, we do experience a cost reduction. The other thing that is one time is we also had a very good year. We did not have significant stop-loss claims in that year, and typically we will have those. So when you look at it in combination, those two factors were really the biggest drivers. The prior change, which was really the change in the benefit structure, so we went from 100% benefit coverage to a deductible plan, also had impact in that prior year. So I will say this, we are about out of those cost-saving opportunities. We don't expect a tremendous amount of employees to continue to migrate to Metro Health Select. We believe that it's pretty well settled in where it's going to be. So unless we move to change benefits, we are probably not going to experience any more one-time changes in the way that the healthcare projections look. So our inflation rate, if you believe that inflation in healthcare is 6 to 7%, we will start to trend to that unless we do something to impact it.
So, Mr. Chairman, you said the estimated number for 2014 is 74 million, is that correct?
Correct.
And what's your best estimate on what the number is going to be for 2015?
Dan, what do we project? We've got, oh, I'm sorry. We're projecting about 74.6 million in 2015.
So you're only projecting a 1% increase?
Correct.
Within 2016.
So we've got 2016 and then 2017, we've projected 2% increases out that, 3% increases out on the out years.
If the national trend is 6 to 7%, how are we expecting to keep ours down to those numbers?
So again, we've had some migration. We had the reduction of the Kaiser plan, so we expect those 238 people, or excuse me, 283 people to migrate to lower cost healthcare plans. That is one component of it. Dan, you want to address the other two when we looked at it?
Yes, and then also the Metro Health Select Plan, because the county has a direct contract with that facility and its affiliated locations, we are able to control our own discount. Therefore, we've reduced that industry standard trend. We about cut it in half. So we could kind of maintain a 2 to 3% increase on that population alone.
Okay. How many do we expect on Metro?
I'm sorry, from the last open enrollment, which occurred in October, we are expecting in 2015 to have 2,629 enrollees.
Oh, okay.
MMO showed 1,579 enrollees, United Healthcare 1,577.
Great. Anything further? Mr. Germano?
The auxiliary things that we do, like the lunches and non-smoking, so on, is it having an effect? Is it quantifiable? I'm just wondering.
Yes, I would say that it is quantifiable in a couple of different ways. So today in the wellness program, it's actually integrated with the medical plan. So we allow employees to earn back portions of their deductible or up to the total value of that deductible, $250 or $500. They can earn portions of that or all of it back based on completing wellness activities. So we are tracking today about 36 ICD-9 codes to be able to show a rate of return that we expect to probably have by the end of 2015. We are seeing reductions in the number of diabetics that are uncontrolled. That was sort of an immediate thing that we've seen. We have seen a reduction in the number of musculoskeletal issues relative to county employees, which is the largest expense that the county has. So we do expect to be able to produce a reasonable return on investment in terms of what the county spends in that equation. But I think it's also important to understand that from the wellness perspective, because the plan design is actually integrated, meaning as you get healthier, in order to elevate in that status level that employees have the ability to elevate to, if you don't engage, meaning you don't do anything to get healthier, your deductibles are essentially higher than those people that do engage. So we know just based on that the wellness program is being paid for through that process, if you will.
Thank you.
Anything further? Okay, well, thank you for your testimony.
Mr. Chairman, I would like to point out that our, pardon me, our stop-loss coverage won't be presented to the council until January due to the manner in which we have to show statistics in order to procure the stop-loss of the full current year. That RFP is currently out on the street and is due back in 2 weeks. And then we make a pretty swift decision based on that, but unfortunately it won't come to the council until January.
That's fine.
Thank you.
Thank you. I'll accept a motion to move 2014-0258, 0259, and 0260 to the full council for second reading. Any further discussion? All in favor? Against? Thank you very much.
Thank you.
Miscellaneous business? Seeing none? Other public comment?
No one has signed in.
None? Thank you.
Well, very well run meeting.
Well, good.